Welcome back to the Deep Dive. Today, we're talking to anyone who's a physical therapist, an occupational therapist, a speech-language pathologist, or anyone who manages a practice that employs them.
And if that's you, you already know the topic. It's that one big bottleneck.
Right. It isn't the clinical care. It's the paperwork. Specifically, Medicaid credentialing. Okay, let's unpack this.
Yeah.
We've pulled together sources that they paint a pretty brutal picture. We're seeing providers who are routinely facing these long delays.
Oh, absolutely.
We're talking 4, 5, sometimes even 6 months.
6 months before they can see their first Medicaid patient. It's a huge time sink, and it's just devastating for revenue.
It is.
And that's really our mission for this dip dive. We want to turn this whole process into, well, an administrative win. We're looking for those strategic keys.
Things that can take that 6-month waiting game and shrink it.
Exactly. Shrink it down to just a matter of weeks. The goal here isn't just, filling out forms. It's about executing a really strategic, high-stakes process.
Because the cost of these delays it's just so substantial.
It is, and it goes so far beyond just boring bureaucracy. For the provider, those months will translate directly into cash flow strain. It's lost revenue you just can't get back.
And for the patients?
For patients, it means limited access. It means these agonizingly long wait times for therapy they really need. So this process, it's not just administrative.
No.
It's a critical part of public health and of organizational growth, for that matter.
It's so frustrating that a process that's meant to ensure quality and access actually becomes the biggest barrier to getting that care, which, it begs the question, why? Why does such a vital process take so long? What are the systemic reasons for this massive drag on the timeline?
What's fascinating here is that the delays are, they're like a perfect storm. It's provider error colliding with a system that is just seriously under-resourced.
Okay, so a two-front problem.
Exactly. Yes, credentialing protects patients. That's the goal. But these systemic issues, they just compound the timeline dramatically.
Let's start with the provider side. What's the most common mistake?
The most common delay internally is still the application package itself, just an incomplete or inconsistent one.
So simple things.
Very simple things. We're talking missing documentation, an expired license, or tiny errors, like an address not matching between your tax ID form and your liability certificate.
And that's enough to stop it.
Oh, yeah. Any of those issues will trigger a rejection or, at best, a manual review. And that pushes your file straight to the back of the queue.
So we have provider errors on one side, but what's happening on the administrative side? What's the bottleneck there?
That's where the systemic challenge really hits hard. First, you've got all the state-specific variations. Every single state's Medicaid system is unique.
Which has to be a nightmare for multi-state practices.
A total nightmare. But the biggest structural problem is agency staffing. We saw data from the National Association of Medicaid Directors, the NAMD, and it's frankly alarming.
How bad is it?
They found that staffing vacancies at Medicaid agencies average around 17% nationally.
17%, that's already a lot.
It is. But in some states, they're seeing shortages as high as 30 or even 40%.
40%.
Yeah. So when a critical government function is operating at, less than 2/3 capacity, you get these huge backlogs. Applications just sit there, idle.
That paints a really clear picture. You can't control the fact that the state agency has a 40% staff shortage.
Right.
But you can control how easy you make it for the one person who finally touches your file. Which brings us to our leverage point, the actionable steps. Based on the insights we pulled, what did the experts identify as the absolute fundamental first step?
It all starts with quality control. Step 1 is to tighten your application package.
Before you even think about hitting submit.
Exactly. You have to act as if your application is undergoing an immediate audit. Verify every single required document. Is it present? Is it complete, current, and perfectly consistent?
Licenses, malpractice coverage.
All of it. Tax forms, everything. The Centers for Medicare and Medicaid Services, CMS, is crystal clear on this. Accuracy and completeness are the single most important factors.
So even tiny discrepancies will trigger those delays.
Oh, absolutely.
If that's step 1, getting your house in perfect order, step 2 seems to be recognizing that every state is a different house entirely.
Precisely. Step 2 is to use a state-specific checklist. You just cannot assume uniformity across state lines.
Can you give an example?
Sure. Some states might demand proof of specific liability insurance limits that another state just doesn't care about. Or they might require unique training certifications. If you're in multiple states, a tailored checklist is, well, it's non-negotiable.
Because missing just one of those state-specific forms will.
It'll trigger a rejection, even if the entire rest of the package is absolutely perfect.
Okay, now, we talked about the file sitting idle because of those staff shortages. How do we beat that bottleneck? That sounds like our third best practice.
It is. Number 3, track and follow up regularly.
Be the squeaky wheel.
You have to be. Given those high vacancy rates, your file is likely just sitting in a queue. It'll stay there until a person is basically forced to look at it by your proactive contact.
So what does that look like in practice?
You need a rigorous tracking system, a CRM, calendar reminders, something, and you follow up every 2 to 3 weeks. That proactive outreach, it signals that you're monitoring the progress and it keeps your file from, gathering dust.
Tracking helps you get in. But staying in seems to be the focus of the next point. How does a practice protect itself from having to restart this whole 6-month process all over again?
That leads us to number 4. Stay ahead of compliance deadlines. Credentialing isn't a one-and-done thing. It involves periodic revalidation.
And missing those deadlines is.
It's catastrophic. If your revalidation lapses, your enrollment can be suspended. And that often forces you to restart the entire application process from scratch. It wipes out months of work.
And we have data on this too, right?
We do. The Kaiser Family Foundation highlighted back in 2021 that these compliance lapses are a leading cause of provider participation disruptions.
So the solution is just discipline.
Total discipline. Assign a specific staff member to it. Create a centralized compliance calendar with advanced reminders, not just a week before, but a month or 2 before the deadline.
And finally, number 5, which sort of integrates everything we've been talking about.
Right. Number 5 is all about that foundational consistency. You have to build an internal credentialing file.
A digital one, preferably.
A robust digital file, one that's instantly accessible and constantly updated. Current licenses, insurance policies, tax forms like W-9s, organizational records, resumes, all of it.
And this serves 2 purposes.
2 big ones. First, it reduces that scrambling period we'll talk about in a minute. But maybe more importantly, it ensures consistency across all of your applications. And this is vital, because you aren't just applying to the state.
You're also applying to managed care organizations. And that distinction state versus MCOs is a massive nuance. We absolutely need to dive into that now. So let's start with a quick definition. When we say MCO, what are we talking about?
MCOs, or managed care organizations, are they're essentially the private insurance companies that are contracted by the state to deliver Medicaid services.
So in a lot of states, patients aren't directly with the state agency.
That's right. In many states, the majority of Medicaid patients are enrolled through one of these MCOs. And this raises a really important question. If you are credentialed with the state Medicaid agency, you might think you're ready to go. You can bill everyone.
But you're not.
You are not. Being credentialed with the state does not guarantee you can bill the managed care organizations. Each MCO requires its own separate credentialing process.
So if I'm a provider, I'm potentially facing 2 parallel application timelines.
At least.
One for the state, and then individual applications for what, 2, 3, maybe 5 major MCOs in my region? That sounds like a double workload.
It is, and failing to understand that MCO credentialing is mandatory and separate is where so many providers lose their first critical months of billing.
So you have to incorporate it for the beginning.
You have to. You need to build the MCO documentation requirements into your initial internal prep phase.
Okay, let's turn to some logistics. You mentioned internal prep time. According to the sources, how much time should a provider realistically budget internally before they even hit submit?
The American Medical Association suggests providers should budget a solid 2 to 4 weeks of internal prep time.
Just for prep?
Just for prep. That's the time needed to collect and verify all those W-9s, licenses, policies, and resumes before you even submit. If you skip this part, you're guaranteeing errors. You're guaranteeing delays.
2 to 4 weeks is a huge undertaking, especially for a smaller practice where the administrator might also be handling scheduling and billing for your current patients.
It's a very real challenge, and if staff resources are tight, that prep time absolutely must be prioritized because it directly determines your revenue start date.
So you have to frame it as a financial issue.
That's why tactics like assigning a dedicated credentialing lead are so important, even if it's the same person wearing a different hat. If that administrator understands that a 2-week delay in paperwork costs the practice, say, $10,000,
that application moves to the top of the pile.
it moves right to the top of the pile.
What about group practices versus individual providers? Is it just double the paperwork?
In many ways, yes, and the complexity just goes up. Group practices have to credential both the organization itself and each individual rendering provider.
Which doubles the paperwork and the timelines.
Often, yes. And on top of that, practices need to make a really critical upfront decision about NPI usage.
And for anyone listening who might not be in billing, what's an NPO?
The NPI, or National Provider Identifier, is a unique 10-digit ID number. You have to have one. And you have to decide upfront if you're credentialing and billing under the group NPI, which identifies the organization, or under the individual NPIs of your clinicians.
Or sometimes both.
Sometimes both. And confusion there causes major headaches later on when you're submitting claims.
Now, despite all these best practices, what happens if the application is still denied?
Denials usually stem from those same things: missing info, compliance lapses, outdated credentials. The tough news is that while most states do allow you to resubmit,
You have to restart the clock.
you often have to restart the clock entirely. The most critical step is to immediately request a detailed denial letter. You need to know exactly which deficiencies to address.
Don't guess.
Do not guess. Get the official word on why you were denied before you do anything else.
We have a few other tactical steps we should cover quickly. What are some of those small efficiency boosters?
Okay, a few quick ones. Always submit electronically whenever the state allows it. Electronic applications almost always process faster than paper.
That makes sense.
And for multi-site or multi-state practices, really consider outsourcing to specialized credentialing experts.
I can see some owners hesitating at the cost there.
For sure, there's an upfront fee. But the reduction in mistakes and the faster approval times often yield significant savings compared to trying to handle it internally with limited staff. It can be really cost-effective.
So what does this all mean? The overall message seems pretty empowering, actually, despite all the systemic challenges.
It is.
While you can't control the state staff shortages and the backlogs, the key leverage point for speed is all about controlling the completeness, the consistency, and the active management of your internal application packet.
Exactly. Focus your energy internally where you have the most influence. And don't let your file just sit idle in a state queue for months. Proactivity is profit.
That leaves us with a final provocative thought for you to consider as you wrap up this deep dive. Given that state credentialing often doesn't guarantee you can build those critical managed care organizations.
The MCOs.
Right. And knowing that internal prep is already this major 2 to 4 week time sink, how can you integrate that MCO credentialing requirement into your initial prep phase? Specifically by collecting all the necessary MCO-specific documents during those first 4 weeks. How do you do that to ensure truly seamless service from day one?
Because that comprehensive pre-work is the ultimate differentiator.
It is. Understanding that dual pathway of state and MCO credentialing right from the start, it just changes the entire game plan. That's all the time we have for this deep dive into mastering Medicaid credentialing. We hope this roadmap helps you fast-track your approval process. We'll see you next time.